Hi, as Anna said, I'm Kim Hollandsworth. I'm a nurse at Kennedy Krieger Institute in Baltimore, Maryland, and we're going to talk about telehealth and how Kennedy Krieger has implemented that process. And I'm going to start, and then Connor Murray is going to do the second half of the presentation. So the COVID situation obviously has caused us to rethink patient care. And pre-COVID, Kennedy Krieger did not have a telehealth option for medical clinics. We did have a small infrastructure of telehealth for behavioral psychology. Post-COVID onset, we had a very rapid initiation of telehealth services beginning in March 2020. And more than 95% of our encounters today are telehealth. And we have had more patient encounters this year than the same time last year. Purpose of telehealth: ensure continued services to patients and to reduce barriers to healthcare access during this crisis. And our focus is not only to continue to see our patients, but make sure that the specific services are covered by insurance, that we use HIPAA compliant technology and have the ability to see those who we otherwise may not be able to see. We will follow standards set forth by discipline-specific professional boards, the Joint Commission, the Commission on Accreditation of Rehabilitation Facilities, various payer groups as appropriate, and applicable statutes and regulations set forth in state and federal laws. Since many of our patients are out of state, specific guidelines were initiated. These guidelines assist providers in making decisions about their out-of-state practice. The decision ultimately lies with each licensed provider. As an organization, Kennedy Krieger Institute is supporting and following the federal government's COVID-19 National Emergency Declaration and the Public Health Emergency Declaration, both of which include blanket waivers for all states. One of the blanket waivers is to temporarily waive requirements that physicians and other healthcare professionals be licensed in the state in which they are providing services. So as long as they have an equivalent licensing in another state. In accordance with this waiver, practice across state lines for the following populations was implemented. So we'll see patients with rare disorders, that's determined by the provider or the care team, patients in need of expertise that's not available in their state and who were already scheduled for a visit, patients already on the wait list, and established patients. And it's important to note that providers need to document the reason for the telehealth visit with the out-of-state patients in the body of their note. Kennedy Krieger's experience is that all major insurance companies are reimbursing telehealth encounters the same as in person. There are three types of telehealth: live video, remote monitoring, and store and forward. And the store and forward is the not real-time sharing of information, and it's shared at a later date. And we're really going to focus on the live video option since that's what we use the majority of the time. We are currently using Zoom for our telehealth encounters. This is not yet set up within Epic or MyChart, but it's an option that we're looking into. If for some reason the Zoom fails during the visit, a phone call is made. We also use the Doximity dialer, which is an app to make patient calls from home or remote locations. And our triage nurses use this app when calling patients prior to their visit. The patient number is dialed and a KKI phone number then appears on the caller's ID. So now I'm going to turn it over to Connor, who's going to talk more about the roles within telehealth.
Thank you, Kim. So to help with the transition to telehealth, and really, as Kim said, 95% of our appointments now are conducted remotely. So we've had to transition most, if not all, clinics to develop the capacity to see patients remotely. To do so, to help with that transition, we've come up with a new role at Kennedy Krieger called the Department Telehealth Lead. And this is really someone in each department who coordinates closely with our telemedicine committees to get updated policy information and regulation information, to then disseminate that information to their respective clinics. And if there's new trainings that are required now, then the DTLs are responsible for training their fellow coworkers on those responsibilities. So this is a little overview of the workflow, how the telehealth, scheduling process works. The first step actually isn't shown. It's really the DTLs review patients who are scheduled or who may be scheduled, and coordinates closely with providers to confirm that these patients are appropriate for telehealth. There are some patients based on, what state they live in, or, based on certain examinations that may be needed, that may disqualify or may require them to be seen in person rather than remotely. And so once patients are confirmed for telehealth, this information is relayed to the scheduler, who then sets the appointment and routes the appropriate consent forms to each patient. So prior to this pandemic, we didn't have language in the consent form for patients to participate remotely. So we've developed a new consent form that we route to patients. And only once patients sign this consent form do then the administrative assistants create a link, a Zoom link for the appointment, and then they route that link to the patient and to the provider. We have templates that we've created for the different clinics so that coordinators follow a generic script to route links to patients. And then importantly, we confirm that the patients receive these links ahead of time before the appointment. So nurses do this when they call they do a phone triage 1 to 2 days ahead of each appointment. And during that phone call, they'll confirm with patients that they have or have not received appointment links. The appointment link hasn't been received, then the nurse will relay that information to the coordinators, who then forward the links to the patients and confirm receipt. During this triage call, they also review whether patients have had experience with Zoom. And though most patients, at this point have or already, experienced with Zoom, some are not. And so we found that, gauging how comfortable they are with Zoom, and if they're not comfortable using Zoom, practicing with them ahead of time is extremely helpful. And then come appointment time, if the patient hasn't joined the appointment, then we either the provider or the coordinator will reach out to the patient by phone to check in. And so actually ahead of this time, during the communication, ahead of the appointment, we obtain the best number to use that the patient will be available at during the appointment time. So preparing for the Zoom session, this really applies to providers in particular. Before your camera's on and you admit the patient, you just want to make sure any personal health information is not showing. Just general preparation stuff, have your documents pulled up and ready to share. Minimize distractions for your, on your phone and your computer. If you're in a group text, which we'll discuss in a bit, in a multidisciplinary setting, putting that on, silent or buzzer, then just so you can give the patients your undivided attention. Some providers like to use headphones that can improve sound clarity and reduce background noise. And then as we mentioned earlier, practice sessions for both patients and providers. Some providers haven't used Zoom before, so you just want to make sure they train before they see any patients live in clinic. So we have this telehealth safety policy that is really developed in case there's an emergency during the time of the appointment. At the beginning of the appointment, the provider will verify the identity of the patient and caregiver, verify their own identity, and provide their licensure type. They'll also provide an alternative phone number that they can be reached at. And then importantly, they'll obtain the physical location of the patient during the session. And this is in case there is some sort of emergency, that the provider is able to contact 911 and relay the physical location to the authorities. And then it's important for providers to document this experience in Epic. We have a smart phrase, I believe, for this. And then some more pointers that we've come up with for providers while the appointment is in progress. For them to wear the badge as they would on the clinic floor so that it's visible to the patient. If the patient hasn't consented to participating in telehealth, it's important for the provider to obtain verbal consent and document that in their note. They then inform the family they're connected through a secure Zoom link, and the provider, is where they're located, either on-site or off-site. Then they obtain verbal consent from the patient for anyone who's present to be able to listen in to the conversation. So that goes for anyone on the patient's end. If there are any family members that can possibly overhear the conversation, we need the patient's consent for them to do so. And likewise, if there are any other additional providers who are potentially listening in on the conversation, we need the patient's consent for them to do so. And then after the session, either the provider or the administrative coordinator emails the responsible person for checking families in and out, so we can inform our medical record system that this appointment did occur. So patients aren't coming in and doing this during registration. And so then at that point, the provider will be able to complete their note and complete their documentation. So we have a couple different visit types. This is just very general. So patients will come in and they might see a single provider, a neurologist at 9 a.m. and we create one Zoom link and send it to that patient. In a multidisciplinary setting, we are still sending a single Zoom link per patient. And so you'll see on this next page an example of a general clinic schedule. If this were to be an in-person clinic, the patient one would be assigned as an exam room, and they would remain in that exam room while the providers from the different specialties, would come into that exam room to see the patient. Zoom link functions the same way. It's a substitute for the exam room. So we send a single Zoom link to patient one, and then when each provider is due to see the patient, they select the Zoom link and enter the appointment. In our multidisciplinary clinic, providers from the different disciplines like to consult each other about the patients and how the appointments are going, and then to prep them on the patients that have been seen. So for example, if you look at 10:30, rehab will be done with patient one.
Peraí.
Rehab will be done with patient one, and neurology will be done with patient two. And so at this point, both providers will actually leave the appointments with the patient and jump in this conference room Zoom link number 5. And then they can consult amongst them, the patients amongst themselves. And when they're done, then they can, hop back in to the, respective appointment links. In a multidisciplinary setting, because there is one link being used, and because we do have this conference room for providers to communicate with each other about the patients, we need a way for them to communicate with each other during appointments discreetly. And so one way is that we've, come up with a group text, basically, where providers can text each other, about to be done with patient A, I'll be in the conference room in 10 minutes. And that way, you're not lingering in the conference room waiting for other providers to jump in who knows when. Really, optimizes the efficiency, of the clinic. There's also an option for something called Onedrive. It allows for, this is really good if your clinic schedule is dynamic and it's not a set schedule. If you're not sure which services you're going to offer the patient that day, you can sort of come up with a schedule on demand and a spreadsheet that all team members have access to, and that they can edit simultaneously. And there's also a chat window for them to communicate there. Now, there have been some challenges with telehealth. So far the regulation changes have made it easier for us to see patients, but we expect, in the future, the regulations to change, and that's hard to predict exactly how they'll change. This goes for reimbursements too, with insurance. There is a facility fee that we are reimbursed for, and who knows how that will be affected post-COVID pandemic, and whether we'll be reimbursed for those or not, and then just coming up with sort of an algorithm for, what the reimbursements will be. And then, we've had to definitely restructure some clinics and reschedule patients who were not able to see for due to these regulation or insurance changes. Training staff on the new technology is definitely a bit of a challenge. the learning curves, they're not super steep, but it's definitely somewhat of a challenge to get everyone up to speed on the new skills that are required. And then an important one from a patient care perspective, there are certain exam limitations when conducting, certain exams remotely versus in person. And some patients really do require a hands-on touch. So just real quickly, we'll go over the pros and cons. It's been an overwhelmingly positive experience for us, telehealth has, but there are definitely some challenges and cons that come with it. And so first, the pros, we definitely have increased access to patients. Some patients are not, couldn't cover travel expenses before, and they no longer have to because we can see them remotely. So that's key. There's decreased wait time for scheduling appointments, and this sort of is in hand with the greater flexibility for scheduling. There's less competition for exam rooms. There's no competition for exam rooms between providers right now. So really, they're scheduling, the days that they see patients on, it's less restricted. So we have a bit more flexibility with our schedules, and because of that, we can get patients in a little sooner than we otherwise would. And obviously, it's a bit more convenient for all parties. Patients don't have to fly or drive in, and providers don't either. There are less, 2-hour drives for Dr. Fatimi as a result every morning. And then there are, again, some cons that I've already touched on: regulatory and uncertainty and reimbursement concerns. Something I haven't touched on is just challenges keeping parent and guardian on schedule. When patients come in to a clinic or a multi-D clinic, they're assigned that exam room, and the exam room sort of directs them where to be and when to be there, and they stay there and wait for the providers to come see them. But there are less constraints at home, so when in between appointments, patients could theoretically get up and get lunch while providers are chatting amongst themselves, and then when the provider does join the appointment, we've had some patients not be ready to go at that point. So we found that giving patients a heads up about when to expect the providers to be ready to see them, that will allow the patient to get up and go get a snack and know that they have 5 minutes or 10 minutes. And then, like I said earlier, there are some physical exam limitations, and also there's a decreased social experience for patients. Definitely, I think Kennedy's been very successful transitioning to telehealth and doing it quickly, which is important. And this was really due to, support from our leadership, and everyone shares a common goal of optimizing, patient care and the patient experience. And this was doable through having this telehealth, committee that, I think meets daily, and they update our policy daily. And then they relay this information to our department telehealth leads, who then disseminate it to their respective clinics and departments. And again, so this is really done through utilizing everybody in the employment chain: our admins, our clinic coordinators, our nurses, and we meet, regularly to make sure everyone is on the same page. And then last slide, our long-term plans. Definitely we want to continue telehealth long-term post-COVID, because it does enable us to access more patients than we otherwise would. This will depend somewhat on reimbursements and regulation changes. We need to come up with a hybrid model for seeing some, patients in person and some, for remotely. And then, we're looking into what it takes to get the appropriate licensure for providers, an expectation that, regulations might change, and we want to be prepared for that. And all of this is really to draw more out-of-state patients, especially for rare diseases, making sure that they get the care that, they need and deserve. So that's it. Just acknowledgements. Thank you, Dr. Fatimi, Dr. Lance, Jennifer Johnson, Katie, and Kim for putting everything together. Thanks.
Thank you so much, Connor and Kim. That was a great presentation. What I'm hoping to do right now, so, if you guys have been around us for a while, you know that telehealth has been something that as the LCN, we have wanted for a long time. So it kind of feels like a silver lining of this whole COVID crisis. But I do know that Already, a lot of the allowances that were originally given have been rolled back. So just so you know, Hunter's Hope is working with a group of advocates with some different legislative efforts and advocacy efforts to make it known that this is a very big need for the rare disease community, for the leukodystrophy community, and that we want to see this continue not just through this pandemic, but forever. So what I would love to do right now, I know Dr. Fatimi wanted to address a couple questions that were in the chat. And then Dr. Bonkowsky, I would love to hear from some of the other centers. If you guys, want to share, Dr. Bonkowsky will help moderate that, but I'll let Dr. Fatimi answer those questions first.
Well, I keep it short on the reimbursement side, because that's out of everybody's control here, as you said, and I fully agree that we should be strong advocates of actually patient advocacy groups should be the real advocates of this, because there's less of a conflict of interest if that happens. But obviously, with the rare disease, crossing state lines is the definition, and we have taken the stance because we are basically a smaller institution, not don't have a legal department even. I can't figure that we're just gonna do this, and we do what is best for patient care, and then worry about the legal pitfalls later. Because what is perhaps equally important compared to reimbursement, but wasn't addressed right now in the chat here, is state licensures. And it is just mind-boggling how many crazy limitations each state has decided to come up for each specialty, for physical therapists, for nurses, for nurse practitioners, for physicians, genetic counselors, and so on, what they can and cannot do across state lines. And each state has a different rule. There's this huge grid that we have now looking at. And we've kind of taken a stance, this is in public right now being recorded, that if somebody wants to come and see us because there's no expertise in their state, this is a second opinion, and they were going to see us anyway, we are going to see them. And if I end up in a courtroom having to defend one of our providers, we will do so. So of course that's independent of reimbursement. That's a whole separate issue there. At a place, like our place, the revenues from these rare diseases don't have a big impact necessarily on the overall revenue. So it's to some degree accommodating. But anyway, I'm going to leave it there. I don't want to take really time from Josh. I think there was a question about the exam. I'm happy to add just one quick thing to that. So the things that we can really examine well online is cognitive assessment, eye movements, most of the optic nerves, obviously, aside from smell and the optic nerve itself, but other cranial nerves are very easily examined online. We can assess gait quite well. We can assess cerebellar function quite well. We can assess coordination quite well. What we can't assess well is sensory deficits, obviously, because we can't touch the patients. What we can't assess is subtle changes in muscle strength. And then what we can barely assess is spasticity. Now, there are some proxy things we can do. For instance, for muscle strength, we can ask people to squat. We look very carefully at their gait. We ask them to go down and stand up and so on, just get a sense about lower extremity strength. And for spasticity, you can get some estimate from their gait, but these are things that are obviously difficult and you can't really do online.
Thanks, Dr. Fatimi. And thanks very much, Connor and Kim, for really walking us through an overview of telehealth. I think many of us have all learned very quickly about telehealth. I think the chat, I'm not sure if it's really a chat room, but the chat has had a lot of really helpful comments. I think we've all seen the issues rise with the both reimbursement problems as well as the cross state lines licensure. And I think that is a major issue for all of us to keep a close eye on and try and advocate for. I would like to raise 2 points and then get some input from the group about these, about their experiences or comments. One comment that I wanted to bring up was that half of telehealth, of course, is on the provider side, meaning how we set it up, what platform we use, which software type, and that's there's probably 15 or 20 different telehealth platforms. The other half of telehealth, of course, is on the patient and family side. And so we've seen families run into issues with if they're using a cell phone or what model of cell phone they're using or computer. We've also seen families who live in more rural areas who have broadband connection issues or just don't have internet access. And so that's not an option for them. And the other thing we've seen is sometimes families showing up for the appointment without the patient or child, or trying to do it as they're driving in a car, like to the swimming pool. So I think there's been some interesting experiences we've had with families needing to realize that the telehealth appointment is a regular doctor's appointment. And so I don't know if other people on the call have had these experiences with access problems for patients or platform problems. I think that's been a real navigation point for a lot of us as we've rolled this out. Is there anyone from the group who could comment on some of the disparities they've seen in their access for patients to telehealth?
I would say that, so we have had telemedicine at Mass General for a number of years, and there had been problems in the past. And recently there is a new, I don't know if Brian can speak to this too. I don't know the new platform, exactly it is. It's built into Epic. And since we've done that, we really have not had, I don't have very many families that are having difficulty getting on. I think part of it's also that up here, some of the school districts have made sure that people that didn't have internet access can have it. And having a translator in the call now, they can automatically join, has made a world of difference, because trying to do a phone call with someone with a translator is so much harder.
That's a very good point about the translation services. I think that some platforms are more in tune for that. I've had a call early on where I was holding up my phone with the translator to the telehealth platform, so that was not good. Let's see. It looks like a comment here from someone, from Dr. Regelman, Dr. Rubin, about connections with cell phones and internet access, kind of similar points. Another interesting point that I hadn't really thought about is that it's difficult in some situations to arrange telehealth because of a lack of a private space to do the telehealth visit. So that's a challenge that doesn't have an easy solution, like in a group home type setting.
I think another advantage is, in some ways, you can get a better exam because the kid is comfortable. And so a lot of our kids are playing and are much more active than they are when we see them physically in clinic. So in that sense, I think for some of them, we've actually gotten a better.
How about, have groups or folks run into issues with, there has to be a little bit of a pre-setup, as Connor and Kim was saying, meaning that the nursing team has to reach out often, either hours or day before the visit, to make sure the family is kind of has the software downloaded or is able to get to that. I don't know if other families or other groups have run into that type issue.
Yeah, our schedulers call and get them all set up and make sure they're integrated. And we have Zoom integrated into Epic now, which they're trying to transition everybody over to. And I'll say, when you said, I had a couple calls where they were in the car or the kids weren't there early on. And I think our schedulers have kind of got a hold of that. And so now that we've been doing it a little longer, they're preparing the families a little bit better. So I haven't run into that quite as much recently. So I think it's a little bit of prep work on the front end.
Yeah, I agree. We have the same, you know, we have phone calls leading into the visits that are a couple days ahead of time, and then of course also the day before, to ensure that the families have the Epic platform, which has the video capability sort of built into it, and they try to play to what people have. You know, most often people have iPhones, so at least here we're doing a lot of our visits through the Epic app, which has video capability, and it works like FaceTime. And so, Josh, I don't know if you guys have experience with that, but it seems, I think the easier it is for the families, especially in app form, our compliance is up much higher. But like Brian said, it does take a little bit of lead-in work. But once your families are up and running and they sort of know how it works, after the first run through, it seems to go pretty well.
Hey, this is Emily Hardy. Josh, I just wanted to point out, with people talking about the video integrated to Epic, something that I know that our center struggles with is because we use a different platform for pediatrics than our adult counterparts do, that we don't have that same easy integration. There's 5 more steps for our pediatrics, which makes those challenges even larger.
That's a good point, Emily. I think different centers have, and different families have different healthcare system or electronic medical record systems, which affects the platforms and software availability. One thing that I've noticed, and I'd be interested in both from a family perspective as well as from a provider perspective, is that the interaction via telehealth is very different than an in-person interaction. Some of the subtleties of the exam and of the interaction are diminished. On the other hand, from a provider perspective, of understanding the home situation, which you often get with the telehealth, sometimes is informative. You know, if they're in an apartment or in a mansion or on the beachfront, you get kind of different feelings about what the family is facing. For a family, of course, it's very different if you're trying to convey things over to health versus in person. So I think there's challenges on both sides of that interaction. Would be interested to see what people think about the telehealth interaction versus the in-person interaction.
This is Emily again. From my perspective as a parent, my children had a telehealth visit with physical medicine and rehab, and I loved it at home because my kids were much more natural. Like when they were walking and running, and they could just kind of be in the background while the provider and I were discussing, and then the provider could ask them to do specific things, but they weren't being weird or silly or goofy. They could just kind of see them more naturally. And I feel like from a parent perspective, I have felt like the visit was more meaningful than sometimes they've been in person because of that.
Other families on the call?
So Dr. Eichler, unfortunately, is not here, but he is working with Albert at our hospital with this question about telemedicine for research, because they're trying to standardize the exam so that we could use it for the natural history studies, because that is a big problem right now. We are able to use it for like the gene therapy trial. We're able to use it fine.
I don't know if Amina Smith is on here, but she's also. Amina, are you there? There's too many people here.
Yes. Yeah, I was just going to say, just in terms of like clinical-based research, especially just with this quick transition in the era of COVID, our neurodevelopmental disabilities fellow clinic has actually developed a QI. Our eForm-Q should be going in at the end of the week to try to look at our basically our neurologic exam and especially our developmental testing practices in person, patient satisfaction, provider satisfaction, completeness of the exam. So kind of having a form for that versus comparing in the first couple of months of what we've done with COVID, which has been, essentially very much provider dependent. and figuring it out, and then sort of what things look like after trying to implement some sort of rigor in terms of what we do for the exam and our assessment. And we've adapted some of our assessment tools to be able to better have an interface over a video. So that's kind of one way we're tackling that.
I have one comment about the research-related component. This is the first time I've talked, so we're just double-checking that people can hear me.
Good. Good.
Great. So I have an ongoing natural history study here at Stanford, and something interesting we learned with the onset of the pandemic is, one, that we already had a structured video exam happening as part of our natural history study, and it initially was meant just to look at the quality of their movements, so thinking about a movement disorder. But what we quickly realized is that we could do some of the scores of our normal neurological exams using that same video. And so it really kind of showed us that we probably could use telehealth to do structured exams. Of course, we're going to miss some of the components like Dr. Fatini was pointing out, but when I looked at my neurological exam clinical report form and tried to just score it with the video we already had, which is a structured home video, it actually worked pretty well. I got almost all of my points. And so the way that we do it is we either have the parents upload a video they've done themselves. We send them very standard instructions into a secure box uploader. Or if they're having trouble with that, we can also do the same exam over Zoom, where we record their part of the video by pinning their video. And so we've had some success with that, and I'd of course love to show it to people if they're interested offline. But that was one thing. And then the second thing is that our neuropsychologist did a test where we sent a list of items for people to find around the house because we couldn't send out the kits for their very specific testing. And she tried doing several cognitive tests and motor tests. She thus far has done the Mullen and the Peabody. She definitely couldn't score certain segments, but she was able to come up with some modified scores and actually get pretty good chunks of the testing done. It's of course, you have to think about whether that's considered valid when it's only certain components, but for more severely affected children who sometimes we have to skip a lot of the assessment, so far it's actually been relatively successful. So those are two ways we were able to navigate things once everything shut down, because those are things that we tended to do in person before.
Thanks, Maura. That's some really helpful comments and insights. There's an interesting thing in the chat here about in the UK, the use of telehealth and how to facilitate the kind of ancillary testing that sometimes we need, such as blood tests, or I think another big thing that we often need are MRIs or other radiological procedures, which I think is an opportunity for how do we work with patients and outlying facilities to kind of a hub and spoke model, perhaps in the future, of specialized centers working more closely with outlying facilities or providers to provide the best care for patients. I don't know, Anna, do we have time for a few more things here? I'm just looking through the comments, or if there's other points that people want to bring up here. Maybe
just 1 or 2 more minutes, and then we can move on to the next group.
Okay. And Anne Rugari, I'm just reading through your comment. It's quite long. I'm trying to see if it looks like the concern is that that they haven't been able to get access to all their physicians because the telehealth rollout has been maybe imperfect across different providers, different specialties. And it could be also that the families haven't had complete access on their side to telehealth. And so I think trying to make sure that we don't leave out patient care in this time, and advocating that if we need to get patients in person, that we can do that. So I think that's a good point. So to kind of wrap it up, I think that we've had a great overview of telehealth from the Hopkins Kennedy Krieger group. And then I think in the discussion, we've really highlighted some key focus things for us to work on. I think one big thing is reimbursement and how to provide care across state lines. I think that's a huge area of opportunity, but also a challenge for us all. I think another big thing we've identified is increasing our familiarity both on the family and patient side and on the caregiver side for how to use telehealth effectively and quotation mark correctly to provide good care. And then finally, kind of looking towards the future, how do we roll out telehealth in the research world and also in providing kind of longitudinal care with elements such as lab draws or radiology and interacting with outlying providers and families who are more distant from leukodystrophy centers.